My name is Brendan Koop. I'm really happy to be here. It's a great honor to be able to come to the Lyric, where so many historic things have happened in atrial fibrillation research and other EP research. So it's a lot of fun for me to be here. So just to quickly introduce myself, I've been working at Boston Scientific for about 22 years. I've done a lot of different projects in cardiac rhythm devices and also in the electrophysiology division. Before we acquired FARAPULSE, we had an internal pulse field ablation program that I was leading the technical work on. And we developed our own generator, our own waveform, our own catheter. And then actually, once we acquired FARAPULSE, we brought the two teams together as a combined team, which was a very interesting time. It was very fun because you had two totally separate groups working on the same problem. And so bringing those groups together was a really fun and interesting experience because we got to compare notes and argue with each other and see what each other had done. So it was great. What I do now is, and we'll talk a little bit about this briefly tomorrow, but I lead some of the next generation PFA system development and therapy for the systems that will be coming up. So all I'm going to do now is I'm very acutely aware that I am the last talk of the day. So my goal is to be interesting and brief. So I promise to try at least do the brief part. You guys can judge whether it's interesting. I think there may be some questions, so I'll try to, and then you can interrupt. Please feel free to interrupt along the way. Thank you to Dr. Duchateau. His talk earlier today was perfect for introduction to PFA fundamentals. I have a much longer version of this and I had to cut that all out, and he covered a lot of it. So this is really the only general background slide I will show. And the first disclaimer is, and we're talking about tissue selectivity here, the first disclaimer is that this chart on the right is overused, and you have different waveforms that were used with different researchers and things like this. But the point of the chart on the right is still correct, which is that tissue types and different cell sizes have different thresholds for electroporation. And that the cell size is really one of the biggest factors in determining whether you can permanently electroporate that cell and kill it, because of the voltage that you can get across the cell from back to front. The largest size cell is going to be the easiest to electroporate. The other advantage, as was mentioned previously, is that we can disturb the homeostasis and the function of a myocyte very easily by simply creating permeability in the cell membrane, which inhibits its ability to activate and actually depolarize and cause cardiac contraction. So those two advantages we're taking advantage of as we design electroporation systems. So what I'm going to do is the rest of this talk, which again will be brief, is to give you a window into what we think through as designers, as system designers for pulse field ablation systems. Sometimes I call my longer version of this talk threading the needle, because it's actually an extremely small design space that we have to hit to actually create a functional, safe pulse field ablation system for cardiac ablation. The first point to make here, I guess, is even if you allow some license with some of these numbers, the ordering of these thresholds for irreversible electroporation is broadly very correct. So I will say on myocardium, it's very accurate or close to accurate to say about 400 volts per centimeter is a generally accepted threshold for causing irreversible electroporation. And that is important for the designer to know. It does change. That number depends on your catheter design. It depends on your waveform. Yes,
sorry,
Professor. Yes.
I have a question.
Yes, fantastic. Yes.
It comes from studies that have been done with very different energy,
Yep.
electrodes, unipolar mode, etc.
Yes.
How come it's still there?
Well, it's the first reason it's still there is it's the easiest thing to talk about. The second reason is, like I was just mentioning, it's not a perfect number. So it depends on your catheter, it depends on your waveform, it depends on your polarity. But what I would say is, and we have derived this number for our different technologies, and you can do that by studying electromagnetic modeling and then comparing that to your tissue depth of your lesion and things like that. Between 300 to 500 volts per centimeter is generally, it's between there.
And so this applies to the current technology you are
Correct.
having on the market,
Correct.
even though it's bipolar, etc.
Yep. What? Yes, and it really broadly applies to our future technologies as well, because as we'll talk about tomorrow, we have a number of future technologies coming up. They all have different waveforms, all of them.
And
We separately
threshold is there.
It's basically between 300 and 500, but the interesting thing is, of course, if you give one single pulse, let's just call it a microsecond pulse, that's going to do nothing, right? So just saying that is already misleading, because you have to have what I say, you have to have done your job with the waveform to get that number. So it's very complicated. So, and I don't like, we're trying to get beyond the level of simplicity that we've been talking about PFA, especially this meeting has been great. So that is definitely a simplification, but it's helpful for the rest of the talk to keep that number in mind.
If I'm not misunderstanding, the ratio between this and the accents, for example, is true.
It's broadly speaking true. It's multiples higher for an axon. And then, of course, you can talk about, well, what are you talking about? A myelinated axon? Are you talking about the distal ends of the axon, the GPs? Yeah, I mean, we can get into all those things. But since that is a smaller cross section, it's harder to electroporate. Yeah. So as I go forward, again, this is the only slide I have on just this kind of background. I don't know if you can see my cursor, but we want to be above this threshold. Broadly speaking, we'll just be very simplistic here for killing myocardial cells. And we want to be below this threshold. So this is our in here. Not only that, we want to be within that range in depth. Like we want to get out to the depth that you as a physician would expect to get in the atrium to be therapeutically effective. So we're wanting to get 4 to 5 millimeters at least of depth. So, and doing that and staying within this window here is quite difficult. So I have a very, this is the way I try to explain this. You all are familiar with strength duration curve, especially with pacing. It applies here as well for electroporation. We actually did a lot of strength duration curve work and electroporation. You can imagine, even though there's lots of parameters we can vary with our waveform, one of the most basic ones is what is your pulse width and what type of pulse are you using? And then what's your amplitude? And you can do these types of studies for any type of artifact that you're trying to avoid. It could be skeletal muscle stimulation, because maybe you don't want to require general anesthesia. It could be avoiding red blood cell aggregation on the edges of the electrodes. It could be eliminating all bubbles or arcing. I just call these artifacts. But we also want to create effective durable lesions. And I can tell you, when you first start kind of blindly researching electroporation and you kind of just try things out, these are the types of curves we get over and over. Like we just cannot get these, especially when we started taking catheters off the shelf and starting to test them, just cannot get these to intersect. Like they're just, if we had an effective durable lesion, we were causing problems with other things they were trying to avoid. If we were avoiding those problems, we didn't have chronically durable lesions. And so, and I will say, you know, you can electroporate. Electroporation is actually deceptively not hard to do. You can electroporate, as you may know from the history of cardiac PFA development, with the defibrillator. You can electroporate with a defibrillator, and you can be effective. And you're talking about millisecond long pulse widths. So there's a lot of different waveforms that we and the talented people that I work with at Boston Scientific have used to create effective durable lesions. They just had a lot of other problems. And so the trick is not in actually getting to an effective durable lesion, it's avoiding all the other stuff. So when we talk about breaking a large pulse up into smaller pulses and playing with the spacing and all this stuff, it's a big misconception that we're doing that to like almost crack the DNA code of myocytes or something like that. All we're really trying to do is to get the thing to work without you having to worry about all these negative artifacts. That's the biggest thing. It's not the effectiveness side. So what do we do to get these curves to cross? We want to be in this this little sliver here. That's the needle we're trying to thread. You can get these curves to cross. You have to play with three things that I call the three-legged stool. So that is the catheter design, the waveform, and then your ablation workflow. Those three things are the most important tools you have to actually get yourself to be in that little window. And so just objectively speaking, it's great working with FARAPULSE technologies because we play with all three of these legs of the stool. I can tell you if I was handed a catheter, even a competitive catheter, and said, here, make this work with your waveform, I would be like, we have to start over and redo the waveform because if the catheter is already designed, and you can't change the surface area and you can't change the spacing, and it's already been through some other study that means it's at least safe. Now make it work for PFA. It's absolutely possible. You can do that. And we've done it even when we were learning on some internal catheters. The problem is to take that leg of the stool away if you're trying to optimize your PFA is very difficult to deal with. Like you want to be able to control everything about the catheter and then marry the waveform with the workflow and to get all those things working together. I can see you have a question, Professor.
I was wondering, so I suspect like others, you're working on having a focal catheter.
Yes.
That you can
We'll show that tomorrow.
PFA.
Yes.
Okay, very good. So did you do what you just said?
Absolutely.
So you redesigned the PFA specifically
Yep.
for that type of electrode?
Yes, we redesigned it specifically
Okay.
for that. Yep. And the reason we did that is because some of these other catheters that we see have other requirements, like we want to do high density mapping or something like that. So now you're doing yet another thing that you're trying to do with the same catheter. And so they require different development. Okay, just real briefly on catheter design. And we've been talking about a lot of weird things that we don't understand with PFA, such as why is there any phrenic nerve paresis, transient paresis? And as Professor Jai mentioned earlier, that one case that Jim Hansen had in Copenhagen has actually resolved. So as far as I know, I don't know of any permanent case, and you may know there may be one. So it's not like it's impossible, and certainly 6 months is a long time to deal with something like that. But 1 out of 30,000 is pretty good. There is a transient, let's say 0.4, 0.5% rate of transient phrenic nerve paresis. Why does it happen? Isn't this tissue selective? So let's just look at this. I use this as my basic test mule. This is our intellectual experiment. We have a bipolar catheter, a focal catheter. It's got 2 electrodes, plus, minus. And of course, if you're doing a biphasic pulse, you're flipping those back and forth. So we want to get our lesion out to a therapeutic depth for the atrium. So we want it out there 4 to 5 millimeters, which means this white line here needs to be out 4 to 5 millimeters. We want that, let's just accept 400 volts per centimeter, 500, 400, whatever. We want it to be out there so that you can make that deep of a lesion. But then nobody talks about what's going on inside here. So like, look at this field here. It's already above 4,000 volts per centimeter. And if you actually zoom way in, now you get to the limits of your modeling, but it goes over 10,000 volts per centimeter right up at the electrode. So you're already over the limit that we even talked about, the threshold for like nerve tissue. So if you're treating a right superior vein, and we know patient anatomy differs and the course of their phrenic nerve is different for everybody, but some people have it right there. It's just right behind the wall. And you're pushing really hard because it's hard to get to the right superior, and you're maybe putting more applications there and things like that. It's definitely absolutely not surprising that you would have 0.4, 0.5% transient phrenic nerve paresis just because of this. It's just being exposed to a higher field, if that makes sense. So there are ways to not have this red zone be so big. And the ways you do that is to play with the surface area of the electrode, to spread out the electrodes so that they're not so close to each other. Because if I kept going with the scale here, your biggest field would be right here. So there's lots of design aspects. You can change the amount of edges you have to the surface area. There's lots of things we can play with. The other thing is edges we have a saying internally is mow edges, mow problems. So we definitely get concerned when edges are coming into the equation because those are the nucleation points for things you don't want to have happen. Arcing, especially red blood cell aggregation. So if we come and say, okay, we look at this here, these edges, the highest current intensity points are where the bad things are going to start. And if somebody comes and says, oh, I want to put another electrode inside that electrode, we have to pay attention to that because if there's another edge we have to look at. And if manufacturing comes and says, we have a different way of making the electrodes on the FARAWAVE, but it's going to have a little pinhole in the beginning, right in the middle. And then we say, no, we're not doing that. You can probably guess I didn't make that story up. So that was a real story. So we always have to pay attention, not just the length, but also the edges. Here's a case where we just rammed these two electrodes right near each other, just to show you what this looks like with a basic 5-packet pulse train. And this is a slowed down video, but you see right between those electrodes are bubbles and little arcs, and that's because electrolysis is happening. There's enough current density to actually split water molecules into hydrogen and oxygen gas. And if you were looking really hard, you probably saw that it was only happening on one side. So it gets into like the chemical reaction of what's happening there. It's hydrogen bubbles that you're creating just through electrolysis, not through heating. So we obviously want to avoid that. This was also mentioned by Professor Jai earlier today. There's FARAPULSE actually did over 600, I think it was 700 animal studies to optimize this. Again, it's so helpful when you can start from zero and just design the catheter just for PFA. This is still the only catheter on the market or even near the market that is specifically designed for PFA, that didn't have to make compromises in something because it's designed for that. So this catheter it had an 8-spline version, it had a 10-spline version, a 6-spline version. It had a version with like a sail in the middle with like a balloon to like make the field go outward. The size, the number of electrodes, all of that was optimized. So there's everything you see here was done for a reason. There's definitely a reason for 5 splines. There's definitely a reason for the exact number of electrodes that are there. Even between the 31 and 35 millimeter devices, you would think for efficiency, we would just reuse our electrodes from the 31. The electrodes on 35 are different electrodes. They're longer by a 0.5 millimeter, and the spacing is different. So even just between those two sizes, it has been optimized for PFA. So these other two here, I'm not a third of the way through my presentation, more than half, so these are shorter. I'll just make some comments briefly on these two. So the waveform. This is kind of an iconic plot at this point. You see the first company that got out into humans and actually was changing things and looking at what is the durability. And having to redesign things. The workflow is a part of this. I'm only on the waveform part, but the workflow was a part of this, certainly. They only started with 1 to 2 ablations, and now we have more. But obviously, there were other things like the waveform. We changed from monophasic to biphasic pulses, and that's because we wanted to avoid skeletal muscle stimulation and other effects. And then there definitely were other evolutions of the waveform. So this is why optimizing your waveform is very important. And you also are designing your initial waveform for usually a swine model, and then you get to humans and something else may happen. The biphasic change was strictly made. This is a very nice study. I think this is Damian Miklavčić's study in Slovenia. But somehow they got people to a volunteer for having needles put into their calf muscles, stimulate, look different pulse trains to stimulate, and then It's the only scientific paper I've ever laughed out loud at. There was a pain scale from 1 to 10 where 10 was excruciating. And some people said that was a 10. So it's like, you volunteered for this. That's interesting. So the biphasic pulses allow you to avoid more skeletal muscle capture, partly because you're avoiding just the neuromuscular, the actual nerve transmission and the signals by reversing them. So that's something that's obviously useful, but actually it's harmful for PFA. It makes it less efficient to do PFA to disturb the cell wall. So we had to double the voltage, and you still had a benefit from that. That's one little insight. The rest of this, again, is to get rid of the things the bad things we don't want to have happen. So we want to basically play with the pulses to charge and discharge the membrane. We want to do two things. We want to avoid bad stuff, and we want to be efficient. So a defibrillator is not efficient. Like, you're actually overdosing by quite a bit with having that large pulse, especially if you were to repeat that pulse many, many, many times. So we want to dose just enough to get to our maximum effect, but not so much that bad things happen, or so much that we're actually harming our generator, because this can be really hard on the generator. And for anybody who has been out there and had their own generator fail, we're very aware of the challenges there. So that's one of our highest priority problems, is to make sure our generators are working in the field. So we want to have the right spacing to optimize kind of the resonance effect. Like, so we're not working when we don't have to. We're kind of like pushing the cell wall and letting it mechanically be damaged from the charge buildup, but not so much that we're just doing needless work. So we play with the number of pulses, the spacing, all that. Also, you're trying to certainly avoid heating and other things. So all this just to say, we're balancing lesion efficacy and durability with the negative effects there. And I won't spend too much time here. I'm sure there may be questions. The last part is the workflow. Again, another thing that's not often talked about, I was so happy that Dr. Duchateau talked about it, was that when you go down, if you zoom in during a pulse, at the cellular level, that electric field has a direction. It's not this like omnipresent field that's like acting everywhere. It's got a specific vector at the cell field, at the cell membrane. So in its most simplistic form, you look over here to the left, and cosine of theta is 1 when it's 0. So then you get the full effect of electroporation, and cosine of theta is 0 when it's 90 degrees. So you get nothing over here. There's no transmembrane potential at all, perpendicular to the direction of the electric field. So that's fine. Maybe we don't need that. We can electroporate. If you're looking at myofibrils like wrapping around the PVs, they're all going to be affected differently by the local electric field, depending on the direction that they're being exposed to the electric field. Certain edges will get more poration than other edges, and more variety. And that's what I'm kind of showing here with this red coloring, is you will have kind of a heterogeneity in the field. So one thing that would certainly be useful, especially if you're designing a system and a catheter, everything together, is that you would change the direction of the electric field. So changing the direction of the electric field locally will expose those cells to their membranes to a more circumferential or spatial coverage of poration or permeabilization. And that's something that we do with the FARAWAVE catheter. So having these two different forms, the basket form and the flower form, it's beneficial certainly because it's kind of form fitting to the anatomy. Every anatomy is different. We don't just say, hey, we have a balloon and it's this size. And, for PFA purposes, I hope your anatomy looks just like that. It's conformable as we change that to the person's anatomy that you're treating. But the other aspect is, as you rotate and then as you change from basket to flower or vice versa, you're getting these overlapping zones where the field is actually hitting the cells from different directions. And that's at least in theory, we feel is more effective rather than just having a linear type of field that you're kind of trying to connect or something like that. This is really a spatial ablation, not just like a linear or point ablation. So even if we talk about posterior wall, which by the way is off label until we have indication for that. But if somebody, in the future, as we study this in our studies, when we're looking at posterior wall, it's really not posterior wall isolation, it's posterior wall ablation. Like you're literally taking out the entire wall because you have this spatial, like volumetric ablation that's quite large. And then as you change the field, you can kind of, at the local level, have a different effect on the cells. So for right now, that's all I had for you. Certainly happy to entertain any other questions.
Thank you so much. It was really super interesting, and I learned a lot listening to you. I was wondering, so I understand that different configuration and rotation will compensate for potential, let's say, pitfalls in the field.
Yeah.
It also maybe plays a role with respect to the orientation of the cells.
Yes, that's exactly.
Because the cardiomyocytes are super long.
Correct.
And pretty narrow.
Yes.
So maybe
that's exactly the point is that as you change, particularly from flower to basket, but maybe less so on just rotating, but changing that form. As you like, if I was to show kind of the field lines here, we've got field lines kind of going circumferentially between electrodes. And then when you change to flower, they're almost kind of going orthogonal. They're going out and back. And so that's part of the design that's inherent to this system.
Do you have reasons to believe that you have better efficacy with 31 millimeters versus 35 from an engineer standpoint?
Yeah, not when positioned well. The catheters are designed to give you the same field and the same depth. Mechanically, the splines mechanically on the 35 are the same material, the same diameter. So if you're going to make a longer spline, it's going to be a little bit easier to move it. So if somebody was using a 35 and it really shouldn't have been selected for that atrium because it's too small, or maybe they're not as skilled at manipulating the catheter, whether it's in basket or flower, those splines can kind of move around and it's maybe slightly harder to get them evenly distributed. It's a super useful tool if you've got CT and you can see a large atrium and a large common or something like that. You just maybe want to be diligent with your positioning to make sure that the splines aren't gathering and you're not missing a spot. Otherwise, there's no reason to believe they'd be different.
Thank you. That's very important. So if I understand well what you just explained, I suspect there is a theoretical advantage of having this type of catheter with bipolar waveform as compared to a sphere with unipolar, because the amount of variation you can apply is much less.
It's less, but I'll show you. It's really dependent on what's the job you're trying to do. So if you're trying to do a focal ablation or you're trying to do a line, and it's not that this is the deciding factor. Like this is absolutely better, and if you don't do this, you will fail. It's certainly maybe an incremental improvement. And so it's not that you would have to do this. We ourselves are looking at different waveforms in future catheters, bipolar and unipolar, monopolar. But we want to do that intelligently with the knowledge that we have.
In my mind, there is a theoretical advantage of using unipolar in the sense that, at least for linear lesion, probably, it would probably penetrate deeper in the tissue because of the unipolar delivery. Would you agree with that?
That's exact. If you had talked to me 1 year ago, I would be like, yep. So I've stopped talking about, like I was thinking, as mentioned to you on the break, PFA in general. PFA does not require force. PFA does this or that. We've learned a lot internally in our research department in the last year. The answer to that question will be different for the catheter type. Focal catheter has a different current density and a different actual pressure on the tissue than even a globe catheter that's maybe 1 centimeter than this catheter. And then there's monopolar, bipolar. So automatically just saying that I used to even think this too, like monopolar, it's got, too much skeletal muscle stimulation, but you can always be deeper. It's absolutely not true. You definitely can maybe at your limit get a little bit deeper, but you can also be very shallow. And if you didn't match the waveform to the form factor of your catheter and take into account some of the dynamics of the biophysics, basically, really just electromagnetics of what's going on there. That's probably the most I can say there, but the answer is absolutely different for a different catheter.
But it's probably true to say that for a focal catheter that is looking like the RF catheters we are using, it's better in unipolar as compared to bipolar, because bipolar, you have basically very little control on whether you're going to lie perpendicular or parallel, and it would be very different if it's bipolar.
So I have a great slide on that tomorrow that I'll show you with lesions, but also, again, depends on what you're trying to do. If you're just trying to ablate the CTI, maybe bipolar works well because it's a kind of a linear lesion within the catheter, and you just go to the annulus and then kind of pull back, and you're getting overlapping lesions.
But this is oversimplified as well.
Yes.
Sometimes we have to loop in and get the point.
Absolutely, you have to like come backward, like 100%. Yes, and you can, yes, and so we kind of have both. But I do agree with you that in the RF focal catheter, if you do your job right on the waveform, that you can get deeper with monopolar. And I have a slide on that tomorrow.
And more controllable, I suspect.
At least maybe it's more intuitive lesion shape. So like you don't have to think about your angle to the tissue. Yeah.
Thank you. Absolutely.
Yeah. Yes.
It's working. Yeah. So for RF, there is 3 buttons to play with: temperature, power, time. That's it. And it took 30 years to have some sort of standardization.
Mm-hmm.
Like a few years ago, there were still talks on should we do 40, 50 watts?
Yes.
And it's still a puzzle. But at least we come to some sort of standardization, and we're able to compare the study and to talk the same language.
Yes.
With electroporation, I see there is hundreds of buttons everywhere. Do you think we will reach at some point some sort of standardization and be able to compare the study, or it will be, everybody in his own line and no comparison between study?
Broadly speaking, I don't think we will ever get there. So what you see now on our generator is effectively at this point like one button, and underneath there's like 200, and that's where I say it's completely understandable to want to know like more of the details, other than we certainly wouldn't want to be playing around with those settings, because it took months and years to optimize that to not have the bad things happen, not necessarily to make the lesion better and better and better. So if you start playing with that, probably it's amazing how quick we get out of that little sliver of a design space. And so that's why I wouldn't even be comfortable being handed a competitor's catheter. I would have to derive the waveform. However, maybe in the future, I don't know, outside my control, but like the pulse width is certainly, that one thing is actually interesting, because companies are working on nanosecond. We've said publicly we're in the microsecond scale. You can go even higher than that. So those types of things I think may be of interest to people. I don't know if that will ever be public or not. I can tell you, like when we derived our waveform internally and then compared it to the FARAPULSE waveform, we were shocked at how close we got to each other. I guess I'll just leave it there. Like, it's just too much. The fact that even in our own catheters, we don't have the same waveform. I mean, how can it be standardized? So, yeah.
It's very interesting because I think it will never be standardized, but I also think that clinical results will be close.
That's very possible. Your maximum lesion depth is really controlled by your amplitude and your catheter design. So that's going to get you where that whatever that magical 400 volts per centimeter between somewhere, that's going to get where that is. And then the rest of your waveform design is just to fill that in to its maximum level. You know, so I think the results will potentially be similar, but we'll have to see.
So I understand that the energy delivered is bipolar, and
Yes.
between the poles of one spline, or also between different splines.
It's between splines. It's between splines.
So if you have uneven distance between slides, the
Exactly.
energy
This is
delivered will
exactly
be
why we stop. The generator will stop you if the splines get too close. It's not just because you're going to make a bad lesion, but also they'll be arcing. So we just have a pre-pulse and we say, okay, this is the impedance is out of range. You have to reposition. It's also why you want to have the splines nicely symmetrical.
But also, I mean,
Yeah, please.
You know, at the maximum interspline distance, right? That's going to dictate the lowest field gradient. As he showed, the field gradient falls off with distance. So if you think about as they get a little bit closer, the field gradients are going to go just higher, still produce effective lesion, except in the area where there's a little bit of asymmetry. So,
Right.
you know, it's not that there's a huge void, and that's why we do a rotational application as well, so that you fill in areas that were previously low gradient
Yes.
with areas of high gradient. And that's a purpose of why we do the rotational applications.
Exactly. And that's also why the 35 millimeter has different electrodes. It's because that space is actually different at its maximum.
So I understand if you insert it into the CS, it will not function. You cannot
Insert it
you cannot
into,
deliver
absolutely, no, you won't.
any energy.
We would have to change something about how we do that, like, yeah. Yeah. And I should say too, on like, on the symmetry of results with other PFA, it's not that, I mean, I think the depth, broadly speaking, is probably, you know, going to be your maximum depth. You can't go to infinity with PFA, right? But this is also, I will say, the reason why we have this catheter designed the way we did is, I think you will see, and maybe have seen in some of the clinical results, there is there's difference, you know, like in performance. So I think having the leg of catheter design in your wheelhouse to control is important.
Any other question before we stop and tour you to the research institutes? No questions? Oh, plenty of questions.
Uh-oh.
Only this one, okay. As the orientation matters, would it not be better not to move or rotate the catheter every time you deliver an application?
Yeah. So on the one hand, you could do that, but again, like Scott said, like the area between the splines is, for this design, is getting less of a field gradient. However, you know, we want the rotation. We want the rotation and the shape change because we are able to have different field direction. So you would be losing that, I guess, if it's not that it's not possible to do that with a different catheter design, but you just have to think about that.
Now, just out of curiosity, my understanding and my experience is that initially the catheter was designed for the flower pose. And in some patients, we had difficulties deploying in flower, and then we thought, let's do some basket.
Yep.
Which may be better.
Some of this, so I will say initially it was designed for the basket.
Okay.
And then the flower was a happy accident of like over deploying, like actually looking at it like, oh, look at that. And then at that point, there was a lot more interest in the flower. So you're 100% right, because you have a lot of history here. This flower was the main starting vehicle. But then as the waveform and workflow, that's why I said workflow evolved, they added the basket and the rotations and extra applications.
And so my question was, you did some fine tuning of the waveform to be optimized for both poses. Is that right?
Yeah, it's the same waveform.
It is, but
Yeah.
I mean, I suspect that
But
some
the
waveform.
catheter design was optimized.
Yeah, okay.
Yes, once you have that waveform kind of where you think you're operating, then the catheter design is your other variable that you can control. If that makes sense. Yeah,
So if no further question, I'll give the mic to Niles.